Okay? I've mentioned this one already. Yung diabetic ketoacidosis natin. By the way, ayan o, lack of insulin, you have your GI upset, you have your febrile illness. And in the span of 4 to 10 hours, pwede kang magkaroon ng diabetic ketoacidosis. What are the signs and symptoms? Ayan, you have your acetone death, you have your Kussmaul's respirations. I have explained that one already. You're thirsty. There is dehydration. There is your tachycardia, hypotension, acidosis. There is your high blood sugar, hyperkalemia. Okay, initially hyperkalemia, and then you have your polyuria. Polyuria and your hypokalemia comes after. Okay, but initially hyperkalemia kasi nga meron kang metabolic acidosis. Tandaan niyo ha, pag meron kang metabolic acidosis, bagsak din yung hydrogen mo dyan. I mean, bagsak yung pH level mo. Maraming hydrogen. Okay? And eventually, when you have excessive polyuria, saka lang lalabas yung ating potassium. So, initially, it's hyperkalemia, and then later on, when you have so much of your dehydration according to you, you will have your hypokalemia. So, anong pinakagagawin mo dyan? What are your interventions? Patient, number 1, always, priority is always your hydration because dehydration ang problema ng DKA. Afterwards, you can control your sugar level by giving your insulin drips and correcting your electrolyte imbalances. That's basically it. So, that is high for the treatment of your diabetic ketoacidosis. Okay, let's move on to the next complication. We have your HHNS. Ngayon, para mas maintindihan natin ang difference ng dalawang ito. By the way, for everyone's information, DKA is for your DM type 1. Yan. But your HHNS or your hyperglycemic hyperosmolar non-ketotic syndrome is a complication for DM type 2. Gets? Okay, so, ayan, explain natin. Bakit? DKA, mabilisang nangyayari. But your HHNS, medyo matagal. Kasi nga, meron ka pang insulin dyan eh. Precipitating factors, infection for both, and other stressors for both, inadequate insulin dose for DKA, and poor fluid intake for your HHNS. Nakulangan ng tubig. Okay? Manifestations, Kussmaul's respiration, fruity breath, nausea, abdominal pain, DKA yan. Pero sa hyperosmolar, wala kang makikitang ganyan. Ang makikita mo doon, LOC changes, irritability, medyo restless siya, okay? Something to do with your neurologic functions. And the next, ang pinaka-problema ng DKA is your dehydration or your electrolyte loss. Kasi nga, meron kang polyuria, meron kang polydipsia, meron kang weight loss, payatot si patient natin, dry skin, sunken eyeballs, you have your lethargy, and then your coma. So, ang number 1 priority intervention is to provide your IV fluid stat. Yan talaga. NSS. Yan. In some other cases, dapat mga D5LRS. Yan, para hindi daw bumagsak ka agad. Bawal kasing ibagsak ka agad eh. Or else you're going to have problems with your osmosis again. Osmotic pressure. In HHNS naman, same. It's your dehydration and your electrolyte loss. So, kung ikaw ay mag-handle ng pasyente na nandun sa emergency department, tapos, by assessment, you know that, okay, this patient is DKA, and another patient comes in, which is HHNS. Ang una mong gagawin dyan is not to prepare your insulin, but prepare your IV tray. Kasi mag-i-insert ka dyan at magbibigay ka ng fluids. We have several cases wherein dun sa emergency room, unang binibigay namin, hayan, 1 litro kaagad ng plain NSS. Kasi nga, dehydrated ang pasyente mo. Hindi naman masyadong obvious kasi nga, meron siyang LOC changes, but most definitely inside. Okay? In the internal anatomical structure, kulang na ang blood volume at circulating blood volume dun sa katawan ng taong yun. So, in the span of 30 minutes to 1 hour, naubos namin yung 1 litro, and that is to actually catch up with the problem of dehydration for patient who has your DKA and your HHNS. Okay? Naintindihan? Okay. Oh, yan. Sa laboratory findings naman ng DKA versus your HHNS, ang serum glucose level na makukuha or the laboratory of serum glucose level result for your DKA is more than 300 mg per deciliter. Okay? For your HHNS, since this is gradual, this is insidious, it can go to as much as 600 to 800 milligram per deciliter or even more than that one. Bakit mas mataas? yung hyperglycemia. Tapos, hindi ka nagkaroon ng masyadong maraming problems. Kasi nga, meron ka pang insulin eh. Compared doon sa DKA mo, having a very high level of 300, more than 300, without your insulin, that's, that's like suicide. Masyadong mataas na yun, considering the fact na wala kang insulin. With your HHNS, meron ka pang konting insulin. That's why it will continue on. Kasi nga, meron pang tinitingnan yung katawan mo, meron pa siyang insulin. So, sige, taas ng taas ng sugar. Kasi nga, it's an attempt of the body to regulate how they're going to regulate the insulin function. Next, osmolarity is variable, more than 350 milliosmol. For your serum ketones, of course, with your diabetic ketoacidosis, kasi wala kang insulin, at kailangan ka magkaroon ng energy. So, ginamit na yung adipose tissues, you have your positive ketones. Pero sa HHNS, wala namang problema sa insulin dyan. It's just your cells sensitivity to your insulin. So, in your HHNS, wala kang makita na ketones. Okay, I'm talking about ketones here, okay? With your HHNS, no ketones. But with your DKA, there is your ketones. Each level, it's acidotic. Okay, less than 7.35. With your HHNS, it's alkalotic. Okay, alkalotic. For your serum bicarb, it's less than, kasi nga acidotic. For your hyperglycemic, hyperosmolar ng ketotic syndrome, you have more than 20. More than 20. Serum sodium, no, low, normal, or high. No, same for both. Okay? Serum potassium also. Kapag meron kang acidosis, will obviously follow, but meron kang elevated potassium. Tandaan, mag-partner po yan. Pag mayroong acidosis, meron ka din hyperkalemia. Naintindihan. Okay? Pero kapag meron ka namang dehydration, at yung polyuria mo ay talagang massive naman, you will expect that there will be hypokalemia. But with your HHNS, there's not much electrolyte problem. Okay? With your BUN, excuse me, your blood urea, my gosh, sandali lang. Your blood urea nitrogen, mataas siya. It's 20 mg per deciliter, elevated because of your dehydration. In like manner, it's also elevated with your HHNS. Same din para sa creatinine, kasi nga ang problema dito yung dehydration mo. It's actually going to increase because of the presence of your dehydration. And then, sabi ko nga kanina, urine ketones, positive po. Negative para sa HHNS. Okay. So, that's the comparison between what are our interventions. Ano mga dapat natin gawin. Sabi ko kanina, di ba, kapag meron kang pasyente na pumasok doon sa emergency department, tapos, ang problema ay DKA or HHNS, kailangan mong gawin dyan ay to treat your dehydration first. First and foremost, it's your dehydration. Okay? So, rapid IV infusion of your 0.9 or your 0.45% normal saline as prescribed. Okay, the most practical thing we did in the emergency department is that you have to insert IV, start. Okay, at the same time, orders of the doctor for 500 cc NSS, fast drip. Hindi pong in 15 minutes to 30 minutes, naubos mo na yung 500. Sabi ko nga, meron pa yung instances wherein in 1 hour, yung buong NSS na 1 litro na ubos namin. Okay, and then we are going to check again. Kasi CBG check mo, tapos very, very high, di ba? Makita mo doon sa result. So, bibigay ka agad yung ating IV fluids. After the administration of your IV fluids of fast drip, kukuhanan ulit ng CBG yan. It's going to be checking if, the sugar level has responded, or if it's also going to check if, the dehydration problem is corrected. Okay? So, next, we have dextrose is added. Okay. After you have done something about your dehydration, hindi pwedeng forever na magkaroon ng NSS lang. Kasi, the initial attempt to decrease your sugar level was done very, very rapidly, and that should not happen. Kasi it will result to more problems. It will result to osmotic pressure problems. So, and then it will also result to your hypoglycemia. Initially, di ba, meron kang hyperglycemia, kaya lang, because you have provided very large amounts of fluid, biglang babagsak. Nakakatakot yun kasi you need to do it gradually. So, in order for you to maintain that, okay, huwag mong bibiglain yung pasyente mo, kailangan mong bigyan ng dextrose. Yung NSS mo, pwedeng maging D5-LRS. Okay, D5-LRS, yan siya. So, dextrose is added to your IV fluids when the blood glucose level reaches 250 or 300 mg per deciliter. Okay, so, with your acute treatment, okay, when you have your acute treatment mo, nag-start na tayo ng treatment natin na meron na siyang dextrose solution. Ayan. Ang mangyayari dyan, yung glucose level mo might start to drop. Glucose level will start to drop kasi nga, sobrang NSS yung naibigay. So, to prevent your hypoglycemia, okay, to prevent hypoglycemia, yeah, dextrose is added. Yan yung pinaka-reason kung bakit meron tayong ganyan. Okay? Hindi sa gusto mong dagdagan yung sugar level yan. Hindi sa this is contraindicated. It's an attempt to normalize, okay, in a slow and consistent manner yung ating sugar level. Kasi nga, dehydration, di ba? Nabigyan mo ng sobrang daming NSS. So, that is how you treat your dehydration. To correct your electrolyte imbalance, most especially that your hyperkalemia happens with your metabolic acidosis initially, and with your dehydration, you are going to have to give your, your insulin. Okay? Insulin po. Because there is increased potassium, kailangan mong ipasok yung sugar. Along with your sugar, yung potassium pumapasok din po siya sa cell. Okay? Naalala ninyo, piso, potassium inside, sodium outside. Di ba? And for everyone's information, your insulin does that job. Paano? Okay? Since this is your cell, right? This is your cell. Your glucose needs to go inside. And this is your bus. This is your insulin. Okay? In order to go inside, your glucose should be on top or riding with your insulin or riding on your insulin. And in like manner, kasama ni glucose, hindi nyo alam to. I think I mentioned this one in your biochemistry. Kasama ni glucose is your potassium. Kasi potassium inside, sodium outside. So, kung sobrang dami ang potassium doon sa circulation mo, as a result of that acidosis and your dehydration, then pwedeng i-correct yan ni insulin kasi sasama si potassium at glucose papasok doon sa cell. So, your insulin therapy can actually do the job of fixing that hyperkalemia there. Naintindihan? Okay? Next. Monitor potassium level closely because your patient, sabi ko nga kanina, will receive treatment for your dehydration and your acidosis. So, kapag nasobrahan naman yung insulin therapy natin, yung pasyente naman natin magkakaroon ng hypokalemia. So, alam mo yung trial and error talagang ginagawa natin para sa pasyente depending on the patient's response. Okay, so depending on the patient's response. Now, if we have hypokalemia as a result of that, over-regulation of your insulin, then you can provide your potassium supplements. That's how we do our electrolyte imbalances. Okay? Naintindihan? Okay? You need to check your potassium levels here because yung potassium natin might indicate problems with your kidney. Okay? Kidney failure. And okay? So, that's how we are going to intervene for our patient suffering from your diabetes mellitus. Okay. How do we treat hyperglycemia? Anong gagawin mo kapag may hyperglycemia ka? There's a lot of ways on how we can do this one. Apart from, we have your OHA. With your OHA, okay lang yung OHA eh. Kasi nga, maintenance medication naman yan eh. ang kailangan mo nang bigyan consideration is when you have your hyperglycemia in patients who have your, in patients who have your DM type 1. Yan, mga insulin-dependent na diabetes mellitus natin. So, kapag sobrang taas ang ating sugar level in DM type 1, magbibigay ka ng insulin IV bolus yan. And then, we have this, pre-mixed na mga doses of insulin na pwedeng ibigay sa ating, or incorporate in our NSS. So, we now call it your IV insulin drips. Okay, so apart from that IV bolus that you're going to give to your patient who is suffering from your hyperglycemia, you also have your IV insulin drips. Okay. Usually, nakalagay siya sa, syringe pump. Yan. Nasa syringe pump po ito. If you have been my student, hindi pala kayo yung student sa clinical area. If you have been assigned in ITRMC pediatric ward, meron doon may mga patients doon who have your syringe pump. And in your syringe pump, I hope you can remember what syringe pumps looks like. 50cc yun 50cc of your parang malaking syringe. Ayan siya. Ayan. 50, 10, 20, 30, 40, 50. 50cc, guys. 50cc. The doctor usually orders your insulin drips in, in equal ratio of your insulin. Ibig sabihin nito, there is incorporation of your insulin in your solution. So, you have 50 cc of your NSS plus 50 units of your insulin. Okay? Naintindihan? Ang isang unit ng insulin ay 0.1 cc sa iyong tuberculin syringe. Nagets? So, ibig sabihin, yung buong 1 ml mo sa tuberculin syringe, that is 100 units of your insulin. So, 50 units means 0.5. 0.5 cc of your insulin. Huwag niyong kakalimutan yan kasi nga, there are instances wherein, newly graduate nurses or maybe students do not understand the calibration of your insulin drips or your insulin natin. Hindi, pag sinabi natin 50 units, hindi siya ibig sabihin 50 cc ha, hindi. Kasi nga, ang insulin syringe natin comes in the form of 1 cc syringes. Okay, so sa buong 1 cc syringe na yan, 100 units na yan. So if you're going to incorporate your insulin in your NSS, ganyan ang itsura niya. Konti lang, konting-konti lang. Be very mindful about the calibration of your insulins. Okay, next. Oops, let me erase that one. Saglit lang. Yan. Ayan. Ang unang gagawin mo is, i-flush mo yung insulin to the entire intravenous infusion set and discard the first 50 to 100 ml. Kung hindi insulin syringe, kung hindi syringe pump ang gagamitin mo dito, pwede naman yung volumetric chamber natin, yung Soluset. Pwedeng ganon. Okay, this is how we would like to connect yung ating, yung solution natin with your insulin and your IV infusion. Always place the insulin infusion on an IV infusion controller. Hindi po pwede itong roller clamp. Hindi pwedeng bilang-bilang. Kailangan accurate po ang ibibigay natin sa pasyente. So, it's either your syringe pump or your anong tawag ng machine na yun? Infusion pump. Okay, infusion pump or your syringe pump. That's it. Insulin is infused continuously until subcutaneous administration resumes to prevent a rebound of your blood glucose level. Yung aming treatment of your insulin usually is is done after you have checked your CBG. So, you cannot give your insulin without checking your capillary blood glucose. Magtutusok ka muna doon sa kamay mo, your finger pads, and check if there is your sugar level. Kapag mataas, magbigay ka ng insulin. Kapag mababa, of course, hindi mo ibibigay yung insulin more as the patient will be suffering from hypoglycemia. Naintindihan? Okay? Kailangan mong, there's a need for your CBG reading before insulin administration. Hindi po pwede na magbigay ng insulin if you do not know your capillary blood glucose reading. Because if you make a mistake of administering your insulin to your patient without knowing your capillary blood glucose level, without knowing na hypoglycemic pala ang pasyente mo, you can cause the patient's death. Understand? We have several instances of that happening to our patient. Okay? That is your CBG. Next, take insulin or oral anti-diabetic medication as prescribed for every time that you're going to have. Again, I will reiterate this one. Okay? CBG reading first before insulin. Okay. Oral anti-diabetic agent is usually taken in after breakfast. Okay? Determine the blood glucose level and test the urine for ketones every 3 to 4 hours, most especially if you are confined in the hospital or maybe even just at home, because you would like to find out if there is already the setting of the complication on the patient. If the usual meal plan cannot be followed, substitute soft foods 6 to 8 times a day. It's better to have your small frequent feeding with your controlled controlled carbohydrate percentage in your diet rather than having binge eating of your food. If vomiting, diarrhea, or fever occurs, consume liquids every 30 to 60 minutes because there is an incidence of your dehydration. Remember, for your complications, you would like to avoid that one, so provide calories as well. Notify the healthcare provider if vomiting, diarrhea, or fever persist because, if you have these are your predisposing factors why complications happen. So, blood glucose again needs to be monitored. If it's higher than 250 to 300, then that would mean DKA. When ketonuria is present for more than 24 hours, or when the patient is unable to take food or fluids within the period of 4 hours, that would mean DKA. And when illness persists for more than 2 days without medications at all, that would mean a red flag. You need to go to the hospital and report the manifestations to your physician immediately. Okay? I would like to just emphasize that the patient who is suffering from your diabetes mellitus will not consistently have hyperglycemia. There are moments in his lifespan where he will be suffering from your hypoglycemia and your hyperglycemia. So, during these periods, you have to be very mindful about your CBG reading. Because if you know that the patient is suffering from hypoglycemia, then you know what to do for the patient. If you know that the patient is suffering from hyperglycemia, then you know which medications to prepare. Okay? So, it's really being vigilant about reading these capillary blood glucose. Sometimes, most patients refuse to have that kasi nga, masakit. It's painful when you try to prick your finger pads. Hindi ba? It's very painful to have your finger pads pricked. And then just so that you can have your blood glucose reading. But in time, when you become very conscientious enough about your sugar level, then it's an advantage for you because you know what to do for yourself. You know what to do if in any case something goes wrong. Okay, so it is very important that you follow protocols. Okay? We have instances in the clinical area where, alam mo yung, when we did our bedside rounds, we were caring for a patient who was diagnosed to have, I'm not sure, I totally forgot the diagnosis, but he was an old man, I think around 72 years old or 67 years old, and I forgot the diagnosis, but Because we were in the 3:11 shift. No, 11 to 7 shift. Yeah, 11 to 7 shift. And when we did our bedside rounds, well, obviously, during that specific time, people are actually sleeping. But we would like to find out if, the patient was just, it was not, 3:11 pala. It was 7 to 3. 7 to 3 shift. Along with the staff nurse, and then along with the students, we checked the patient and asked ko, Mami, yung wife nga, Mami, kumain na ba si tatay? And then the wife mentioned that he has not eaten yet because he hasn't woken up. He was sleeping and maybe he is very, very tired. So when we tried to rouse him, try to wake him up, what we hear from him is just your snoring and nothing at all. We even tried checking the vital signs, and it really did not bother him. He was just sleeping the whole time that we were performing the BP, taking, etc., etc. So we were quite worried because at around 9 o'clock, still the patient wasn't eating. He needs to take the medications during that time. The first hour of giving medications was around 8 o'clock. So at around 9 o'clock, we were wondering really what's wrong with the patient because he's not waking up even if we try to shake him. So when we try to check the patient's, sugar level, the glucometer cannot even read the sugar level of the patient. It is on error. We tried to change the strip several times, even change the battery, but it was really on error. It means to say that the blood sugar level of the patient was very, very low. So immediately we reported it to the physician, and an order of your B50/50, dextrose 50, B50/50, was given intravenously to your patient. After 30 minutes or an hour of giving the medication, the patient woke up. So imagine that. It was a very close call. The patient might have gone into shock or comatose if we weren't able to, assess him appropriately. I mean, it was even late already, considering that the glucometer cannot read the sugar level anymore. So imagine that one, dying because you don't have enough sugar level. Okay, so the B50/50 is an emergency drug for patients who have your unconscious, hypoglycemia. There you go. Yan. And, in some other institutions, they have their glycogen administration. Remember glycogenolysis, sugar? So, glycogen administration also provides you enough of the sugar. Okay? So, that is for hypoglycemia. Kasi nga, your hyperglycemia is already being resolved by the use of your insulin in your OHA. Okay! As a last discussion of your HHNS, your HHNS compared to your DKA is extreme hyperglycemia but without your acidosis and your ketosis. And mostly, it affects your type 2 diabetes mellitus. And again, the difference between these two, your HHNS and your ketosis, is that there is no acidosis and ketosis in HHNS. And compared with your DKA, I mean, patients who have your HHNS can have, mas better yung prognosis nila because you just need to resolve problems about your dehydration and your hyperglycemia. So, if you are going to ask me, the DKA complication is much worse than your HHNS. Okay? So, that is your HHNS and your DKA. Interventions, what can be done? Same. DKA, you have your high. HIE, you have your dehydration, treat the dehydration, you provide your insulin, and you give your exercise. Okay? Next. So, okay, that ends our discussion on diabetes mellitus and even your DKA and HHNS. Please read more about your insulin administration. That is your homework, insulin administration, and your OHA. Okay, so I hope everyone learned something about our discussion for today. And I did mention that your DM talaga is very, very long. Okay, so thank you very much for listening and have a good day.